Cecile Fraley.
Oh, on the phone.
I'm on the phone muted, thanks.
Patricia Givens.
She will be in the phone. She's probably not there yet.
Simon Hambich.
Present.
Brigida Hughes.
Present.
Jessica Coombs.
Here.
Amanda Moore.
Present.
Charlotte Lipolis.
She's excused this morning.
Ann Nguyen.
Here.
David Potts.
Here.
Donna Roberts.
Present. And it is Amanda's birthday, so everybody wish her a happy birthday.
Happy birthday, Amanda.
Thank you guys.
Should
Appreciate
sing
it.
the happy birthday. No, we won't. We won't. We won't.
I got a 4-year-old rendition this morning.
There are all sorts of verses to that if you really want to hear them.
Thank you.
I'm fun at parties. Let's go on to the minutes. I would entertain a motion for the approval of those minutes.
So moved.
Seconded.
All in favor?
Aye.
Opposed? Abstain? Passes. All right. We have an emergency rule document. I'm going to ask Andrew. I'm going to wait. You're waiting for it. Okay. Obolus. It's an O instead of an I. Okay. Will you come on up? This is document 5 MSB 18-02-12-D. And we are getting ourselves into federal compliance. And providers should be happy, 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 I understand. According to my fearless leader over here.
I have with me Kevin Martin, the fee-for-service rates manager for the department as well. Morning.
Good morning.
Morning. Good morning, Dr. Givens. We've already started.
Hello, thank you.
Go ahead.
So this is really just a very technical change to the UD modifier within the EAP or with the enhanced ambulatory patient grouper methodology. It's 1%. This is in reference to the 340B program as it is delivered by outpatient hospitals. That's a program that allows outpatient hospitals to purchase drugs at the discounted rate that Medicaid receives it at, and then they are obligated to pass those discounts along to us, but they can also use those discounts for other payers as well. As they pass those discounts on to us, that means that for our payment methodologies, we are trying to discount them to approximately what they purchased them at. And unfortunately, when we were setting up the new enhanced ambulatory patient grouper model, we did not have sufficient information to actually calculate that percentage. Now that we've gotten about a year past go live, we have gotten enough information to determine that that percentage is wrong. We are still trying to get to the exact right percentage and possibly alter the methodology altogether. However, in the interim, we are trying to make the drug purchasing 340B program for outpatient hospitals sustainable on their side.
Okay. And this is Christy. Are you backdating that reimbursement?
Well, we can't backdate because
retro paying, I guess, would be the answer.
no,
Okay.
because the 50% number is actually in the rule right now, so we can't do retroactive
Okay.
rules. We're a bit generous on the 20% because that is the absolute minimum amount of discount that they should be getting. And that's why we'll probably be back with a more robust calculation at some point in the future. We're just trying to get exactly to that number. We're receiving a lot of new information from both the hospitals and from some of the other governing bodies that administer the 340B program on the federal side, because we don't actually administer the program. It's just a program that flows through to us.
Understood. Understood. Any questions from the committee? Dr. Hammock?
No questions, but this was a hardship, so I'm glad to see that it's, it's being corrected. So
Yes.
Thank you.
So that's a thumbs up. We don't have anybody signed up. Anybody in the audience missed this one and really want to sign up? We've got a gentleman, so we will invite you to come on down and introduce yourself. You can write it after you tell us who you are. You don't need to.
Good morning. My name is Ryan Westrom, and I'm with the Colorado Hospital Association.
Good morning.
Thank you for the opportunity to come before you this morning. I'd like to first start by thanking the department by reviewing this change and increasing the reimbursement for hospitals. As they mentioned, this is an importance for our hospitals, and I appreciate their willingness to look at this short-term fix as well as a long-term fix. I just wanted to recommend your support for this and let you know that the association is in support of this as well. So thank you for your time.
So you're going to put a little smiley face on that sign-up sheet, correct?
I
Is
will
that
do
how
that.
we can?
I will do that if we all
Okay,
do, yes.
so that's how we're going to take that? Okay. No, thank you very much for, anybody have any other questions? Anybody else in the audience want to say yay? We love those. No. Okay. Seeing none, I would entertain a motion.
So moved.
Madam Chairman, I'll move that that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with the state or federal law or federal regulation, or for the preservation of public health, safety, or welfare, and that compliance with CRS 24-4-103 would be contrary to the public interest. And I move that the emergency adoption of document 5 MSB 18-02-12-D, revision to the medical assistance rule concerning updates to 340B, drug discount in EAPG and EAPG rate maintenance methodology, section 8.300.6, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
We have a motion and a second, and Dr. Hamage, your way was so much easier than, but it doesn't quite fit our protocol. So we appreciate your motion and would entertain you reading the next one. So all in favor?
Aye.
Opposed? Abstain? Dr. Fraley?
I was an aye.
Dr. Givens?
Aye.
All right, so passes. Thank you very much, gentlemen. And thank you
Thank
for
you.
your positive testimony, sir. Okay, let's move on to the final adoption consent agenda. And we don't discuss this, we just entertain a motion.
I move the final adoption of document 1 MSB 17-10-17-A, revision to the medical assistance rule concerning in-home support services, section 8.552. Document 2 MSB 17-11-03-A, revision to the medical assistance rule concerning nursing facility post-eligibility treatment of income incurred medical expenses, section 8.482.33, incorporating the statement of basis and purpose and specific statutory authority contained in the records. Second.
We have a motion and a second. All in favor?
Aye.
Aye.
Opposed? Abstain? In the phone, Dr. Fraley,
Aye.
Dr. Gibbons,
Aye.
and we miss your faces, girls. So we're excited to maybe see you next month. So passes. Thank you so much. All right, let's go on to document 3, and that would be Russell Ziegler Ziegler. Thank you. I was trying.
You got the traditional.
And Alex Kalaskis. Is that correct?
Yes.
Okay, I said it correctly. Kalaskis.
It's Greek, so you have permission to butcher it.
Okay. I didn't realize that I
Greek
was allowed to
too.
do that. I'll make sure and do that next time, just for fun. Document 3, MSB 18-1-05-A.
Good morning, Madam
Good morning.
President. Morning. Board members, morning as well. I'm Russell Ziegler. I'm the Compliance and Policy Analyst for the department. I'm here with Alex Kalaskis, who's
Excuse me, can you use your outside
Oh,
voice?
sure,
or
yeah. Let me move
really
this a
talk
little
into
bit
the
closer.
microphone, because we're going to blow everybody out if we don't.
There we go. Is that better?
Thank you. So much better.
No problem. I'm here with Alex Koloskis, the Hospice Benefit Manager, to present the medical assistance rule concerning the hospice benefit. The Office of Legislative and Legal Counsel has directed the department that we must incorporate our benefit coverage standards into rule rather than incorporating them by reference. A benefit coverage standard is essentially, it defines the amount, scope, and duration of a covered benefit. In 2012, hospice stakeholders were engaged as part of a benefits collaborative process to create the current hospice benefit coverage standard. The purpose of this rulemaking is to incorporate that benefit coverage standard into rule without making any substantive policy changes. As part of the 2016 regulatory review process, we solicited stakeholder feedback on the proposed rule, and we received no comments or objections. We did receive one stakeholder comment following the public rule review meeting that primarily concerned the use of acronyms and wording of specific provisions. We've incorporated some of those comments, but we notified the stakeholder that the acronyms will be clarified where appropriate. However, the purpose of this rulemaking is just to incorporate the benefit coverage standard. No substantive policy changes are intended. We did receive one question from a board member, and if you can turn to page 5 of the proposed rule, specifically section.
It's page 9 in our,
Oh, it's
in
page
the
9 of yours.
iPad.
Okay.
It's 8.550.3.A. Thank you.
Exactly, and that was concerning whether home and community-based waiver services provided to children under 20 are exempt from the requirement that such services must be unrelated to the client's terminal diagnosis. I'll turn it over to the subject matter expert, Alex Koloskis. Thank you.
Good morning, Madam President, members of the board. Madam President, I believe this was your question.
Yes, ma'am.
So just to clarify that, that's number 2, HCBS waiver services. It says may not be provided for conditions unrelated to the client's terminal diagnosis. And then it's the second sentence is children under 20 are exempt from the requirement that services must be unrelated to the client's terminal diagnosis. All this means is if you have elected hospice and you're an adult and you are also receiving HCBS services, those HCBS services have to be unrelated to your terminal diagnosis because the hospice benefit should be what's treating your terminal diagnosis. But for children, of course, we want them to be able to receive HCBS waiver services regardless of whether they're related or unrelated to the client's terminal diagnosis. So that second sentence simply means that children can receive waiver services and hospice services both, regardless of whether they're related or unrelated to the terminal illness.
I've read this so many times. This is Christy, and I don't like double negatives to begin with. They're my life, but I don't like them. But it still feels to me like that should be related, not unrelated. So,
well, if they
help me.
It is a double negative. And I think we can change this to say that children are exempt from any requirement that waiver services are related or unrelated to their terminal diagnosis and have it be a positive. But the intent of this and both sentences is that they can receive waiver services and hospice services regardless of what diagnosis.
Okay. And so, again, this is Christy. So when we're talking about the children with life-limiting illness, that which is a hospice waiver essentially has hospice benefits, some benefits. We're looking at those kiddos and saying you can get HCBS regardless of what. So it would make more sense to me in reading it if you said related or unrelated, but that's me.
We can certainly make that change. And just for context, this distinction between children and adults is because you have to waive curative care for hospice, and we don't require that of children. So that's where this comes from. You don't have to waive curative care. You can continue to receive HCBS and hospice services regardless of what it's treating for children.
This dialogue has helped me greatly, and thank you. Okay. That makes sense to me. But in my own mind, I was just like, just, reading it out loud to the dog. He was helping me decide whether that, yes.
And I have
Ms. Roberts.
Thank you, Madam Chair. I have a question on your interdisciplinary team definitions, page 2 of 23 or 7 of 27 in our copy. That is the prescriptive language that's written from Medicare,
What
certainly.
line?
Line 1, I'm
Mhm.
sorry. As versus line 18, 18 of 23, or 22 of 27 for our copy. In it extrapolates a little bit more. I assume that this is in statute, the other is just being nebulous. I just like some clarification there.
Yes, that's correct. One is in statute and one's just kind of for reference.
Thank you.
Anybody else have questions?
I also just wanted to
Yes, please.
clarify, the comment we received from the stakeholder was regarding, and I don't know that you can see all the track changes. In this, we had used the term and the acronym SNF for skilled nursing facility, and we went through and changed this all to just nursing facility, and that was, I just wanted to explain that that was because skilled nursing facility, or SNF, references a specific Medicare term or regulation that only means Medicare certified nursing facility. And we, while we don't have any Medicaid only nursing facilities in Colorado right now, I believe we have in the past and we may in the future. So we wanted to include a broader term that would allow a nursing facility to just be Medicaid only and still serve Medicaid hospice patients.
Oh, Ms. Roberts.
Thank you, Madam Chair. I want to express my appreciation for the way you've delineated the services within a skilled nursing facility or nursing facility, and the delineation of their particular responsibilities in concert with that of hospice. As being an administrator for 19 years of a hospice, we oftentimes kind of butted heads because they didn't realize that they needed to provide the same DME, et cetera, that they would for any other resident there. So thank you.
Thank you.
Any other questions, comments? We don't have anybody signed up. Isn't there anybody in the audience itching to say something positive? No, or negative. We'll accept it, I guess.
I do want to, my friend here is from the University of Colorado nursing program, getting her doctorate, and she's here to listen to a public policy meeting. So I wanted to embarrass her in front of all of you.
Okay, everybody,
Point that out.
everybody at the table, please just wave to her. There you go. Don't you feel loved now? This is not normally how friendly we are. These guys really, sweat bullets to come before us.
Bigger one.
Would you like to testify just for fun? Okay, all right. Okey doke. Well, with that, sorry, I'm having a little fun today. I will accept a motion.
Oh.
Sorry.
Move the initial approval of document 3 MSB 18-01-05-A, revision to the medical assistance rule concerning hospice benefit, section 8.550, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second. We have a motion and a second. All in favor?
Aye.
Opposed? Abstain? Dr. Fraley?
Aye.
Dr. Givens?
Aye.
So passes. Thank you very much. And Alex, thank you for coming to explain that to me
Yes,
today.
thank you.
Not just to me, but thank you. I appreciate it. All right, document 4, we have Jennifer Van Cleve. Is she coming by herself or we have multiples? Oh, we should maybe make the nurse students sit with you just for grins. Good morning.
Good morning, Madam President and board members. Thank you for your time today. My name is Jennifer Van Cleve, and I'm the General Eligibility Policy Specialist for the department. I'm here to present the change to medical assistance eligibility rules regarding citizenship and identity documents. There will be no change to citizenship requirements for eligibility, only to those documents that can be accepted to verify citizenship and identity. Currently in 8.100.3.h, it states only originals and certified copies of citizenship and identity documents can be accepted when verification is needed. 42 CFR section 435.407F was recently updated to clarify that photocopies, faxes, scans, and other copies must now be accepted to the same extent as certified copies and originals. Also, satisfactory documentary evidence listed in 8.100.3.h is listed in a 4-tier hierarchy. With this change, we're eliminating the hierarchy to mirror the organization types in federal rule at 42 CFR section 435.407. The satisfactory documents are now listed as standalone evidence of citizenship and evidence of citizenship that must also be accompanied by an acceptable identity document. The Colorado Benefit Management System will be updated with this rule, as well as updating documents on the department's website. Because there's no change to citizenship eligibility requirements, there's no anticipated cost to the department or any other agency, and no anticipated effect on state revenues. In addition to aligning rule with federal policy and regulations, the benefit of this change will be that to potentially eliminate barriers to timely verification submission, which could also lead to eligible individuals being determined and receiving medical assistance sooner. The department would like to thank CCLP and the Center for Health Progress for their feedback to this policy change. And we'd also like to acknowledge the Attorney General for their suggestion in the change. Are there any questions that I can answer at this time?
Are there any questions from the committee? Mr. Potts, you have that face. It's a question face that I can read from here.
It's too bad I don't wear my heart on my sleeve. Madam Chair, I'm trying to understand that, do we have limitations in the state of Colorado as to whom is available and whom is not to receive Medicaid services?
We do, Mr. Potts, but I will let either
I guess
you all to answer, Mr. Massey or
sure. There's in terms of citizenship requirements.
Yes.
Yes, there's a pretty substantial list of different statuses that are eligible non-citizens. There's also citizenship requirements, and then there's also certain parts of medical assistance that can be for non-eligible non-citizens in emergency situations. None of that is changing, though. This is purely just to accept photocopies of documents verifying whatever their status might be, rather than requiring originals or certified copies. So right now, if we couldn't already verify their citizenship electronically with our interfaces, we would send out a request for proof of their citizenship, and they would have to bring in an original and have the eligibility site or county view the original, take a copy, stamp it, certify that they saw the original, and then update their case within the CBMS and run and authorize the eligibility decision. Going forward, this is allowing them to use scans, faxes, photocopies, so that they're not, in some cases, mailing an original birth certificate to an eligibility site and then having the eligibility site have to return it, as well as using the PEAK system right now, which is the system we use for individuals to apply online. We do allow them to upload documents to verify different parts of their eligibility, and so they'll be able to use that now as well for their citizenship.
So this isn't opening any other eligibility, Mr. Potts. It is purely a streamlining for getting documents to the system. But it's
Madam Chair, are these documents confidential?
well, yes. I mean, birth certificates, things like that, passports, things that would be. But instead of sending them to them or bringing hand copies in. So for rural areas, this is like, woohoo, or to their, to their area, county, it is the ability to scan it and upload it. So it's a much more streamlined system.
I understand that. I was going to something bigger, but
You
that's all
were.
right.
If you have any other, okay, let's,
What's your bigger question?
Well, with all in the news on sanctuary states, sanctuary cities, if a person is here without the proper documentation, then they're breaking the laws of the United States of America.
Okay.
And I'm trying to understand if we're giving services to people in the state of Colorado that are not citizens of the country and are not here legally, then that is, in my opinion, that is taking away resources and services to those of us, those people that are here needing these services.
Okay, Madam Chair, can I respond?
yes, yes.
Okay.
Mr. Massey?
That makes sense. I know where you're going with this. We're precluded from providing services other than through EMTALA, emergency services, to non-documented folks here. This is really just to aid. It's really a customer-friendly piece to be able to aid our rural folks and the like to be able to provide documentation. Even C4, the exchange, Health Benefit Exchange, is now implementing, because they hadn't had this previously on their screener, which also has the Medicaid piece. They were out of compliance because they weren't doing citizenship verification. They're now doing that to come into compliance. So every effort's made to make sure that the folks that are receiving services are eligible for services. Again, we're precluded from providing those services to non-documented.
Could I add something, Madam Chair?
Yes, Dr. Hammond.
And my understanding is this proposal actually brings us into compliance with federal regulations.
Yeah.
It helps bring us.
Right.
Yeah.
So just to make that point.
Right, but folks that aren't legally here, the only services that they would get if it was going to cost life or limb, and that's, but
I
so,
understand that,
yeah.
and I don't have an issue with
Okay,
that whatsoever.
yeah,
I'm
so just-
trying to understand what we're doing and for whom we're doing it.
Correct,
This isn't an
and we
expansion.
appreciate your questions. Thank you. Okay, so are you satisfied with all of the, okay. Anybody else have questions, comments? Ms. Hughes?
Thank
You're
you,
being
Christy.
too quiet. I'm glad you're talking.
Thank you, Christy. I just wanted to thank Jennifer and her team. I oversee a Medicaid application site for Peak Vista, and they are very grateful for making this a little bit more customer friendly and simplistic.
Yeah, great.
So thank you.
Yes, I think that it works well for the member and the customer. Obviously, it makes it much easier for them to submit the documents, but it also relieves the burden on the eligibility workers, because if they were to currently receive something that was not acceptable, like a photocopy, they would have to reach out to the customer and ask them to bring it in. So that's a huge step that we want to get rid of.
Right. So this is a positive, and we do have a positive letter from Stakeholder Center on Law and Policy saying that they're in support. You should have a copy in your packet. We do not have anybody signed up for testimony. Is there anybody that wants to speak up? Jump up? Okay. We don't have anybody. Any other comments?
I'll just give a comment from a provider perspective.
Dr. Nguyen.
Being able to be able to provide services to our patients real time. I've seen this become an issue for patients before, being able to provide care to a child who is stuck in the middle of guardianship issues, where one parent retains the paperwork and another parent who has the guardianship is trying to get services for their children, and we cannot actually provide services under a benefit because of paperwork issues. So this actually will make these sorts of things so much easier for our patients. So thank you guys for getting in federal compliance. So.
Yes. Yeah, I agree. This is Christy. I spoke to a doctor this past week that had a 6-month-old who hadn't had any shots, and she was in foster care, and it was because the documents hadn't been able to be found and caught up with her. And so this will streamline that. So appreciate your work on this. So, all right. Dr. Fraley, Dr. Givens, you guys are quiet. Any comments?
Nothing for me. The one thing I would say is we see a fair number of undocumented kids, and they never have services. They never have covered services. So I would say that, yes, that's the law, and also that falls on practices unless you want to decline to see children. So that's kind of a outside the area of discussion, but just a observation.
Dr. Fraley, thank you very much for that observation. All right, with that, I would entertain a motion.
Move that the initial approval of document 04 MSB 18-01-16-A, revision to the medical assistance eligibility rules concerning citizens' identity documentation requirements, section 8.100.3H, incorporate the statement of basis and the purpose of specific statutory authority contained in the records.
Second.
We have a motion and a second. All in favor?
Aye.
Opposed? Abstained? Dr. Fraley?
Aye.
Dr. Givens?
Aye.
So passes. Thank you so much. We appreciate. We need to put consent motions. I would think.
Can we put 3 on with the change that you're asking, with the language change? Can we put that on consent?
Can we put that on
Or does
consent,
that-
or do we have to?
I think you can put it on consent.
I mean, that's
It's a pretty
the-
minor
we
change.
discussed
It's a minor
it.
change.
No,
No.
It's very simple.
Yes.
Okay, so
So
yes,
it looks
then
like 3 and 4, everybody? You okay
3
with
and
that?
4. Okay, so we're going to move to add documents 3 and 4 to the consent agenda. That was my motion. I need a second.
Second.
All in favor?
Aye.
Aye.
Opposed? Abstained. Dr. Fraley?
Aye.
Dr. Givens?
Aye.
And closing motion. I'll let somebody else read it.
Chair, I'd like to move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Health Care Policy and Finance meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
We have a motion and a second. All in favor?
Aye.
Aye.
Opposed? Abstain? I don't think anybody's going to. Dr. Fraley?
Aye.
Dr. Givens?
Aye.
So passes. So we are finished for the closing of the rules part of the agenda. We now are to open forum for public comment. And why don't we do that before the rules close? So it's, I just suddenly had that question and it came to my lips. Any? No. Okay. I do. I'm wondering
Because
now.
there's public opportunity to comment during the rules section. There's no need. This is for alternative discussion.
Yeah, we've already had stakeholders.
Ah, see, I knew somebody was smarter in
That's
this room
my
than me.
vice chair role.
That is so, okay.
Yeah.
So we don't have anybody signed up for open forum. Anybody want to sign up for open forum? Tell us how wonderful Medicaid's doing, how phenomenal, no, okay.
Oh, I get to do that.
Oh, okay. All right, then we're gonna just move right on to department update. Oh, did somebody in the phone? No, I guess not. So we're gonna move to updates and Mr. Tom Massey, I almost made you a doctor.
Oh, thank you.
Congratulations.
Do I get paid more?
And your Chief Operating Officer, Deputy Executive Director. That's a mouthful.
Tell you. Thank you, Madam Chair, and our staff is so good that they've given me a very comprehensive our department update. So I'll gloss through that rather quickly because you're doing so well on time today. It's amazing.
I run a very tight ship.
I tell you. As most of you are aware, we have just confirmed our new executive director, a lady named Kim Bimsteffer. She had been in the healthcare arena for about 32 years. She's now our new executive director. She was confirmed on Tuesday morning, as a matter of fact. So we were thrilled to see that finally pass the Senate. We're glad to have her expertise. It's going to be very interesting to see how we we're being tasked with trying to streamline a lot of our processes and how we control costs in a very member-friendly way, which is going to be quite the task for the next 10 months for the balance of this Hickenlooper administration. So that will be what the department really moves toward.
Excuse me, Madam Chair.
Thank you. Mr. Potts, did you have a question?
Yeah. Help me understand what you just said. To streamline expenses, are we not doing a good job as a state on what we're doing with our money?
That's a loaded question.
Yeah. Do you want me to try to tackle that one?
I did. Madam
Mr.
Chair.
Massey, why don't you answer that
Yeah, thank
very
you.
simple question?
Thank you, Madam Chair.
Explain brain surgery.
Yeah, Commissioner Potts, I would say that yes, we think we do a very effective job. Our total administrative costs for the spend that we make as a state department and running a program like Medicaid, we in fact operated just under 3% administrative cost. So we think we're very effective. We think there's a lot of external factors with some of our provider partners and the way we do business that we can pare down costs. I would reference possibly some of the things we do with our hospitals, some of the things we do with pharmaceuticals and the like. We think there's room to create more efficiencies on the way we pay and the way they provide services. So that's what we're looking at from a global standpoint on how healthcare in general we can bring down costs.
In processes.
It's really process based. You know, the fact that we as an insurer, a public insurer, we have about 1,350,000 clients. We're a very large insurer, so we think we can actually have a significant impact on healthcare costs. If we improve processes, I think the private market, it reflects in the private market as well. So no, that's not to say we don't feel like we do a good job. In fact, we've just gone through a complete rework of our fiscal agent and fiscal package, our Colorado interchange, which was a huge lift. We were still trying to improve from a 1970s technology into real world, real time systems. And we did that about a year ago, March 1st, as a matter of fact. And to date, we've paid about $8 billion to our providers in this year, and processed more than 45 million claims. Yes. Well, in the calendar year from March 1st to when we implemented the new system to current. So just over a year, that's been our span. So we definitely had glitches along the way, and we've worked with our providers and our stakeholders to improve those on a daily basis. We still have some issues we're ironing out, but we continue to do that. We're down to where now there's not a lot of big fixes. We're down to the ones and twos and need to work on an individual basis with our providers. And we take that very seriously. So we're going to continue to work in that vein. We're trying to move to what we call normal operations, which, we're about 85% of the way there. So we're getting very close. So we'll continue to work in that. It's witnessed by the fact that I think y'all were aware that we had interim payments for our providers that were having billing issues, and we had a significant amount of those that we actually put out to our providers that needed it. We now, in fact, are not seeing any more requests for new interim payments. As a matter of fact, we're even starting to see a lot of the providers that we provided interim payments paying back those payments. So that's a very good sign for us. The volume of, we were hearing a lot from our legislative partners down the street that there were issues by individual providers. We're not getting those anymore for the most part. So that's another good sign that we're getting there. So again, we're trying to get to what we call a normalization of operations, and we're very close. So we will keep you posted on that. A couple of updates on department activity, implementation of ordering, prescribing, and rendering provider enrollment requirement. This was effective January 1st of this year. Department began enforcing 42 CFR 455.410B. All ordering or referring physicians or other professionals providing services must be enrolled as Medicaid providers. So to conform with federal law, we need to make sure everyone has enrolled as a Medicaid provider if they're providing services and receiving payments from us. 42 CFR 455.440 says that all claims must include the National Provider Identifier, the NPI, of the ordering, referring, or prescribing physician. So as each provider, when they have gone through the re-enrollment process, had to get an NPI number, and that's our reference number, so we can in fact pay them for the services they provide. Department is not paying for new prescriptions written on or after January 1st if the prescriber is not enrolled. Refills written prior to January 1st, 2018 by unenrolled prescribers will pay until the prescription expires or until there are no remaining refills. Prior authorizations requested by unenrolled prescribers will not be processed effective January 1st, 2018. So we actually are enforcing that now, that they have to be a Medicaid provider and enroll with an NPI. If the provider does not wish to enroll with Colorado Medicaid, they should begin referring their patients to a prescriber who is in fact enrolled. Providers should call DXC, which is our fiscal agent, to enroll, go through the process. It's not too late. You can still do that. To date, we actually have about 56,000 providers enrolled. So we think we're doing very well with the provider enrollment.
Out of how many? Sorry for
the. We can't get a real firm number. I'm going to assume there's probably in excess of 120,000 total providers. By the time you start adding specialty care and the like, the number can rise. CHIP Plus update, as you're aware, we sat on pins and needles for a significant amount of time waiting for CHIP to be re-enrolled. It was, reauthorized. It was in fact reauthorized here recently for 10 years. I will say the only caveat to that is the monies that are providing the funding for CHIP moving forward came at the expense of a provision within the Affordable Care Act, the individual mandate. So it benefits our CHIP kids, but we don't know in long term what that will actually do to our health benefit exchange. We'll have to see how their sustainability works without an individual mandate. So I know we're working very closely with them in partnership. The department notified the CHIP members. You were probably aware we had to send letters out early on that we were potentially losing that benefit. We did send letters out in January saying the program has been continued. You do not have any lapse or coverage and your benefit will continue. So we were glad to finally be able to do that. Spinal cord injury pilot waiver annual report. The spinal cord injury waiver offers services that allow members to live in the community of their choice, as well as to offer and evaluate the effectiveness of complementary and integrative health services, CIHS, for individuals with a spinal cord injury, which consists of acupuncture, massage, and chiropractic. Each year we have to provide an annual report to the legislature. There will be a final report due in 2020. Our findings are right now through 2017 are available online. Most commonly cited result of receiving the CIHS was a decrease in pain. 81% of participant respondents said they experienced pain on fewer days. 87% said their level of pain had decreased as a result of CIHS. We hypothesize that it's better pain management through CIHS, and that leads to a reduced need for pharmaceuticals to manage pain and depression. And early data seems to reinforce that. So we're excited about that. We think that's a plus. We envision adding further providers to our network and increasing the number of enrolled members. We also look for more feedback from those members continuing moving forward for our final report issued to the General Assembly in 2020. Our copay changes. Yes, sir.
Question on that. Since
Dr. Hamich.
you have, thank you, Madam Chair, the positive findings, is there any discussion or consideration of expanding to other groups outside of spinal cord injuries?
I can research that for you. I'm not aware, but I can.
Good question.
I will get you an answer to that. Thank you, Madam Chair. I'm sorry. I'll research that with our subject matter experts and see if we can have looked at expanding that beyond spinal cord injuries only.
Anybody have
Madam
any
Chair,
other?
I had a question too
Yeah,
on the phone.
Dr. Fraley?
Yeah, it's Dr. Fraley. I think there was a recent blog from the Colorado Health Foundation, if I'm remembering right, that actually said the Medicaid enrollment was going to be decreasing. Estimates were in coming years. Do you have any thoughts on that?
Mr.
Thank
Massey?
you, Madam Chair. Thank you. Dr. Fraley, the answer to that is actually we're kind of pleased to see that. We have had quite a conundrum over the last couple of years because as we deal with our friends down the street, particularly the governor's budget office, they have been concerned by the fact that in an economy that is as significant and robust as Colorado's economy, our Medicaid enrollment and caseload has continued to increase. So there's been a significant lag. I will say over the last 6 to 8 months, we're finally starting to see a decrease in enrollments. We've actually had less folks enrolled in Medicaid. We assume they're getting up and off because of the job market is very strong. Our caseloads are going down, and we are seeing our total cost of care going down. We've been very cognizant of trying to make that a significant effort within the department, but so all three are actually decreasing: our cost of care, our caseload, and our enrollments. We think that's a reflection of the strong economy and hope to see that continue.
I think that's great. Thank you. And possibly the RICOs may have a role in that as well.
Absolutely.
Yeah, thanks so much.
You bet.
Any other questions? I had one comment. In recent year, I have become a provider, Medicaid provider, in order to provide for my daughter, provider assisted or approved provider service age, APASA, under the DD system. I know this is humorous. He's laughing at me, but
No.
I did, and it is not painless a system, and there's a lot to it, and most families I don't think will be able to handle it. But I just really want to say the team that supported me in getting me through the provider enrollment was amazing, and Juanita LeBlanc in particular was amazing, and because we weren't without hiccups. So just really appreciate the group, and you can tell that they've really gotten good at supporting people like me that are brand new to whole systems like that.
Thank you, Madam Chair. It's good to hear. I mean, we have amazing staff, and quite honestly, they all believe so strongly in the mission. They're very customer centric these days, and that's you know, anything we can do that eases the administrative burden that our folks face is a significant improvement for us. So that's you know, that's a continuing goal with everything we try to do. It's sometimes difficult with what we see from the feds coming down. We try to do the best we can to mitigate that at the state level, but that's not always possible. Speaking of which, copay amounts changed January 1st, 2018. You need to be aware of that. This is part of the Senate Bill 17267 implementation. Our outpatient hospital visit copay increased from $3 to $4. Our non-emergency ER visit copay increased from $3 to $6. Our generic copay increased from $1 to $3. Generic drug copay increased from $1 to $3. Some prescriptions never have copays. This didn't change, and no changes to which benefits or services have copays. That remain the same.
Madam Chair.
Mr. Potts.
Thank you.
Is this directed at Mr. Massey?
Yeah. Oh, yeah.
Okay. Oh, yeah. Oh, yeah.
Not just Mr. Massey, but to the system. I'm surprised that we still have, with the great system that we have and the great job that we're doing, that people are still going to emergency rooms for non-emergent care. That really surprises me. I'd like to understand that a little more.
Madam Chair, if I could
Mr.
respond.
Massey.
Thank you. Commissioner, a lot of it is an access issue, quite honestly. Our rural, you know, we have some rural frontier areas that are grossly underserved from a provider standpoint. Also, it's a significant cultural change for our Medicaid clients, you know, particularly given our expansion. These folks had never previously had access to Medicaid through a primary care provider. We're used to going to the emergency room for all their treatments because they wouldn't be refused. So it's changing the culture, and of course the access. We need to make sure that more primary care practices continue to see and expand their Medicaid book of business, quite honestly. We need to get more providers in rural frontier areas. Park County is a perfect example. You got a county the size of the state of Connecticut that has no primary care providers now. So I think they have one community health center, and that's it. So, they typically come to Denver or even come south to, Chaffee County for their care. So I think that's a large function of that. The copay thing is a little mixed because most of our docs are still going to provide services to our clients, whether or not they make the copay. A lot of times our physician partners or our medical partners look at this as it can even be perceived as a pay cut to providers because they, for a lot of instances, absorb the copays because they're not going to refuse service. But the issue is really access to care.
This is Christy. It's also an education. So if I'm a new mom and my mother always took us to the emergency room for ear infections or splinters or whatever, and I'm a new mom, that's all I know. And until somebody says an emergency service is not a medical home and you need to have a medical home, and Dr. Fraley probably knows this better than anybody, or Dr. Hamich, but you definitely have an education problem, but you also have an access problem with hours of operation. I'm working 12 hours as that new mom. I may not have the ability to not go to an emergency room because my hours may not coincide. Yep. So both of those things are up against us.
Yeah, Madam Chair, that's an excellent point. Hence, we're seeing, particularly in the metropolitan areas, this advent of all these, freestanding ERs because they offer services, beyond normal practice hours. So again, it's an access issue. So we look for maybe as practices could possibly expand their hours, that could improve some of that too. So that really concludes our department report. Any questions? I'm happy to.
Mr. Potts?
I do have one more.
Yep.
In regards to opioids, this morning on national news, they had the governor of Kentucky on, stating that Kentucky's adopting a new policy that they are only allowing a 3-day script for opioids rather than 5, because it's been proven that 5 is the trigger point for addiction, and that 3 is able to control that better. It puts a little more restriction on the insurance companies and the providers, but at least it will help control that addiction. Does the state have, does Medicaid have a limit on the days of prescription?
They don't hear your nods.
Yeah, okay. Thank you, Madam Chair. Commissioner Price, yes. In fact, our chief medical officer, we actually ramped down our number. I'm trying to remember whether it's 5 days or 3 days. I'd have to ask one of our
it's not 3. I think it's 7.
Is it 7 days? Okay, that's and Dr. Zerzan had recommended we go to 7 days. We've done that. There's several bills working its way through the legislature right now, and the governor is also, and the lieutenant governor, highly involved in paneling experts to.
There's a task force
for
opioid addiction issues in the state. Dr. Hamich, did you?
Sure. Just to follow up on that, I think it's too strong a statement to say that 5 days is a cut point for addiction.
I'm just repeating what was.
Yeah, so I'm just saying that that's not generally accepted medical knowledge. So I'm not sure where that statement came from. There is obviously a range in there, but I think the 7 days was a really good step. I think 3 days actually. There you're talking about legislatures taking on a medical role. I mean, once you go down too low, so I would, I'd be really careful about, ramping down that far. I think that Colorado has taken a step in the right direction.
Yeah, thank you, Madam Chair. I think Dr. Zerzan, when she made that recommendation, was basing on her best estimate of what was medically appropriate. So, but yeah, it's an issue that every state is having to deal with, and Colorado had typically not been one of the higher utilizers, but everybody's got opioid issues, and it's really a cultural thing more than anything else. I was actually listening to the news last night where they're talking about the number of people that pass away from opioid addiction that, you know, have a couple prescriptions, you know, in their bedside table of opioids. So it's very prevalent. So, but we are.
Has response.
Well,
Mr. Potts.
It's very concerning to me because unfortunately Chaffey County is in one of the top 10 counties in the state that has
Mhm.
an addiction. So most interested in that. Thank you.
Thank you. We'll keep you posted on that. So you want to change hats and become Zach? Is that what you want to do now?
Sure.
I think that's what you're supposed to do,
Yes,
Mr. Massey,
ma'am.
is
That-
become
I
Zach.
get to do double duty today. So
Legislative update.
our legislative update. So again, this is Tom Massey.
Where
I
it
did
go? Okay.
briefly
I'm
mention that
paper
Kim
towel.
was approved unanimously in the Senate on Tuesday. These are the 5 department bills, and we actually feel that our legislative agenda is, I will say, we feel like it's rather pedestrian this year in the sense that we don't have anything real controversial. I think the legislature has enough controversy to deal with without us digging in deeper. But let me give you a quick overview of the department bills. We do have 5 bills. First was repeal obsolete persons living with AIDS waiver. In 2014, the department consolidated the first and smallest HCBS waiver known as the persons living with AIDS by transferring the clients enrolled to the elderly, blind, and disabled waiver. CMS approved this consolidation, and Colorado lost its federal authority to continue operating it. Since the waiver is no longer operational and has no clients being served through it, we're going to the Statutory Revision Committee and ask that they strike the language related to the waiver. The status is this week it was unanimously passed by the House Public Health Care and Human Services Committee. It previously passed the full Senate 34-0-1. So it's on its way through the process. Second bill is the redesign of the Children's Habilitation Residential Program, the CHIRP waiver. Previously, this had been housed within DHS. Currently, the CHIRP waiver offers a residential benefit to children with an IDD with complex needs and requires that a child be in foster care in order to qualify. This bill would allow us to bring the last remaining HCBS waiver administered by DHS to HCPF and would redesign the waiver so families don't have to give up their children in order to get them the services they need. The bill would also move case management responsibilities from the counties to the CCBs. This proposal also has a corresponding budget request. The JBC, the status of this is the JBC have approved the budget request and agreed to run the legislation as a JBC bill. The gist of this is parents had to give up their foster rights to the kids to get them into the system. This precludes them having to do that anymore and can remain in foster care. So we felt it was a very beneficial thing for us to move from DHS since we administer the rest of those waivers anyway.
It's also been underutilized at DHS, which is, yeah.
Our third bill, conflict-free case management. Say that 20 times fast. For single entry points, this bill would bring the single entry point system into compliance with the federal rule on home and community-based services from 2014. Similar to the conflict-free case management bill from last year, it will require single entry points to separate case management from service provision. Currently, only 4 of 24 SEPs provide direct services and case management at the same time. The status is we're finalizing sponsors before introducing the bill in the next 2 weeks. Again, we think this is appropriate, and we haven't to date seen any real opposition. Our fourth bill actually, cost savings through transition services and community living. This bill will allow us to keep offering the most effective transition services that were part of the Colorado Choice Transition Grant by adding them to either the state plan or waiver programs such as targeted case management, home delivered meals, peer mentorship, independent living skills. This proposal has a corresponding budget request. The status is the JBC agreed to draft legislation and approve the budget request. The reason for this is, just so you're aware, is previously this had been a grant-funded program, and we can't continue grant-funded programs under our current statute, so we have to actually find another home for this and rework it so it can continue to be a non-grant funded but state-funded program. The last bill is align managed care statute with federal regulations. This bill will align our managed care statute with the new federal managed care rule. Some of the statute is outdated and uses terms no longer in existence. Last year's ACC bill included a reporting requirement on how we plan to update this part of statute with a new rule and align terms for ACC phase 2. Status is finalizing bill draft and will share with external stakeholders in the coming weeks. This is really a come into compliance bill more than anything else. So again, that is our bill package. We have a number of others that we're obviously monitoring. We have taken positions of support on some of the bills that are going through and have testified accordingly, but that is our bill package at present.
Okay, any questions? Mr. Potts?
Thank you, Madam Chair. Under cost savings through transition services and community living, home delivered meals, is that Meals on Wheels? Or is that something different?
It's something different. Meals on Wheels is a separate entity provided by a nonprofit.
So
This is the program, this is Christy. Mr. Potts, this is the program that moves people from nursing home care to community care if that is their choice. So it's a choice thing, and sometimes they address and fund the barriers to having people go out into the community on their own or living on their own independently. So sometimes meals are the issue, and so that's one of the resolutions. And it could be, you know, the ideal is to get a community of support that this person can rely on, but in the short term, it may be delivering meals or.
So that's a time sensitive.
It is.
Transition.
It is, and we continue to move. This program's been very successful, which is why it's going from a grant program to a state-funded program, because it's been very successful in moving people to the community and having them successfully live less expensively. So.
Thank you.
Anytime, Ms. Hughes.
Thank you, Madam Chair. Just a quick question regarding that. Does that community living include assisted living, or is it just home?
I believe it covers home health care under Medicaid, primarily. Home care, but not another congregate living with assisted living. It doesn't cover that.
Okay.
It covers living in the community with support coming in to help if you need personal care.
Got
it. The good news is the legislative session's a little more than halfway over.
Mm-hmm.
I will say we're getting ready to see, it's getting ready to get greatly politicized because we're moving toward what we call the long bill, which is the state budget bill. Will be working its way through caucuses and eventually both bodies of the General Assembly here within the next 2 weeks. From there, it tends to get very politicized, particularly in the campaign years. We're starting to see some of that already. There's a lot of drama last week with the expulsion of a member for the first time in, 110 years. So hopefully some of the rhetoric will calm down, but for the most part, we feel like we're lucky in the sense that because we do run a very lean and efficient program, we tend not to be as much of a target anymore. I think the benefits that our expansion population is starting to see from a population health perspective are starting to pay dividends. So we'll continue to work, and thank you for your work and being our partners and helping us in that process.
Ms. Roberts.
Thank you, Madam Chair. Mr. Massey, is there any bill or any work being done toward behavioral health, mental health deficits in rural Colorado, frontier Colorado? Because we're seeing probably the worst in 27 years out there.
Mr. Massey.
Thank you, Madam Chair. Ms. Roberts, I would say that right now we're in the process of re-procuring our ACC 2.0. Our RICOs will transform into RAY, so we're trying to keep things very confusing. We changed the nomenclature every few
Remind me
years.
what RAY stands for, Mr. Massey.
Regional Accountable Entity.
Thank you.
Anyway, there's a lot more integration of behavioral health as part of the new RAY contracts. So that continues to be a focus because we know we're woefully unfunded from a mental health standpoint, and as far as parity goes, we need to continue to try to enhance that. And a lot of it, we just met with a lot of the advocates yesterday, as a matter of fact, and that was one of the primary issues is the fact that we don't have a really adequate number of psychiatrists in the state. We rely a lot on counselors. So, as we continue to try to backfill where the biggest needs are, that is a focus.
And behavioral health nurse practitioners as well.
Yes.
A good comment and good questions, Ms. Roberts. Anybody else? Okay. As you know, we we entertain you all with previews for next month, right? This is kind of like the trailer for a movie. And you should think of it that way because it's unbelievably exciting. With no further ado, I'm going to call Aaron Johnson up to, I was going to say Aaron Rodgers.
Yeah.
Where did that come from? Wow.
Really entertaining.
Oh, you're not. Wait a minute. You're trying to trick us on this one.
Unfortunately, Aaron Johnson could not make it today.
So you're the
standing in.
trailer.
Yes.
Can you even do that voice? Can you do the trailer voice? Like make it sound really exciting?
Unfortunately, I can't. I'm sorry.
Oh, you surprised me. Okay.
My name is Kevin Martin. Hello, Madam President and members of the board. Next MSB meeting, Aaron Johnson and I will be presenting a rule to change the rate setting methodology for federally qualified health centers. We currently set one encounter rate that is used for an entire federally qualified health center network, regardless of the services that are rendered. But we do allow for 3 separate encounters to happen in one day. And just so everyone knows, an encounter is an individual visit between a qualified professional and a Medicaid member at the federally qualified health center. And we allow separate encounters for 3 different services: dental, mental, and physical health. We've realized through some of our payment reform efforts that having one rate that covers those 3 very disparate types of services creates some very odd incentives at that level. So the majority of the change that we are making is just so that we have 3 different rates to more granularly identify those services that are rendered. But they'll still be able to render 3 separate encounters on the same day. It'll just be at a different rate for the 3 different types of services. There are a couple of other small technical changes that we are making in there. We currently have a separate carved out outstationing payment, which is when the federally qualified health center helps members enroll in Medicaid. This is just something that has been there for a very long time. We make this small one-off payment, and if there are any costs that are left over, then it gets wrapped into the encounter rate. So all we're doing with this is rolling those costs back into the encounter rates as opposed to making that small separate payment. We're also updating the list of qualified providers. Again, these just need updating from time to time as we recognize new providers that are eligible to render these encounters.
So I'm going to ask you all to remember back to last month in Clinica, and if we're going to see a dental provider and a physical health and a mental health, that this will allow them to bill for all of those rather than having only one billing for all of those, which supports the federally qualified health centers and the consumer, that I don't have to ride a bus back and forth 3 times. I can go and get all of my services
No,
Done.
they were actually allowed to bill for each the three
sorry.
of those before.
My
However,
mistake.
they were all the same rate.
Okay.
And that was what was creating the problem because sometimes the physical health is much more expensive. And actually, it varies by federally qualified health center. There are some of them that have a much higher acuity of, say, mental services that they render. And so the mental health rate ends up being higher than the physical. In
Thank you.
general, the physical is higher. But
Thank you for that clarification. Ms. Hughes?
Thank you, Madam Chair. So do you anticipate that that rate for non-medical services is going to be lower now, and we'll have federally qualified health centers upset with now, even though they were billing before just a flat rate for all three? Yeah, what are your thoughts on that?
As we have been working very closely with the Colorado or CCHN, Colorado Community Health Network. Thank you. And they are highly in support of this. Hopefully not to speak too much for them, but yeah.
They're here.
But yes, it would lower some of the visits. Like I said, in not every case, sometimes the mental health rate actually would go up above the physical. It just more appropriately aligns with the visit that is actually being rendered. So in the cases where the mental health rate would go lower, it actually means that the physical health rate would go up by a weighted average commensurate amount. So like it gets complicated in there, but it just means that like, yes, they get a lower payment for that mental health, but then they're actually getting paid for the services that they're rendered in another area.
Okay. Thank you.
Dr. Hambidge?
Thank you, Madam Chair. Just a point of clarification, the additional small wraparound payments you mentioned. So under the new proposed methodology, those will get wrapped into the cost report as opposed to a separate payment, which does mean there'll be then a 2-year delay, right, in basically having an effect on the visit rate. Is that correct?
Correct.
Because of the way the cost-based payment works.
There is still a delay with the cost-based payments. However, changing it from having that separate payment for the outstationing versus wrapping it into the cost settlement doesn't actually change the timing of the payments at all. It just changes the delivery method. Or I guess it might change it a little bit because the outstationing payments were being made as one lump sum at some point during that year. And then it would be, since the cost would get rolled into the cost report and then paid as the encounters, they would get a very small additional amount for every single encounter throughout the entire year as opposed to one lump sum at some point.
Right, but it would kick in 2 years later. Typically that's the delay, right, with cost-based, with prospective payment systems.
Yes, although the outstationing is part of the cost report, so that it was already delayed like that.
Thank you.
Okay. So looking forward to a theater near you. We're going to hear that bill next month in April, and we're just bated breath, worms on tongues. We can't wait.
Great. Okay.
Thank you so much. We appreciate your time. And now we have Colleen McKinney. Are you going to try to surprise me and not be you?
No, I am me.
And can you do it in a trailer voice?
In a world.
Yeah, there you go. See, she did it. Yay. Outpatient substance use disorder treatment rule.
Yes. Good morning, Madam President, members of the board. My name is Colleen McKinney. I am the Managed Care Regulatory Specialist here with the department. Next month, I will be bringing forward 8.746, the Outpatient Fee-for-Service Substance Use Disorder Treatment Rule for revision. This revision is to align with a state plan amendment that was approved by CMS in November. That number is 17-002. So two main parts to this rule are occurring because of that state plan amendment. One, we are changing how we define the providers and the requirements of them to provide substance use disorder treatment. So currently, any provider, a physician, or a clinician like a social worker, counselor has to have an additional substance use treatment certification. So the change in the state plan that happened is that licensed clinicians, social workers, counselors no longer have to have that additional certification to provide substance use disorder treatment. as long as they're providing it within the scope of their licensure. We are still maintaining that additional certification for licensed physicians, psychiatrists. We are also adding advanced practice nurses and physician's assistants to licensed providers, along with the physicians and psychiatrists. And then the other main thing that is happening from the state plan amendment is that we are removing unit limits in the rule for services. Those unit limits are no longer used in the program, but they are still present in the state plan and in the rule. So we are just removing that to align, and the rest is just general cleanup.
Okey doke. Any questions? Wait, there may be questions.
Sorry, I don't understand what a unit limit is.
Dr.
I'm
Nguyen.
Sorry.
So thanks. So a unit limit is essentially a service limit. So as it stands now, it says, it might say outpatient counseling for substance use disorder limited to 30 sessions a year.
Got it.
We are
Okay.
just striking that.
Okay, got it. Thank you.
Okay, any other questions? Seeing none, we'll look forward to reading your rule next time.
Thank you.
Russell, wait for it, Ziegler. Can you do that? Coming soon.
Coming soon to an MSP meeting near you.
Oh, he is quick on his toes. I like that. I like that.
Hello again, Madam Chair and board members. This will be a new rule we're bringing next month. It is essentially community clinics and community clinics with emergency centers are health facilities that are licensed by the Colorado Department of Public Health and Environment. We are creating a new, I'll use the acronym, community clinic and community clinic with emergency center provider type in rule so that such facilities can enroll in Medicaid. So that's the purpose of the rule. Keep it short and sweet unless you have any additional questions.
Any questions? Mr. Potts?
In your experience, what's it take for one of these to be created? Is it a volume of, or a population of a certain number in order for somebody to endeavor to open one of these, or?
I couldn't speak to that specifically. I know that they have to meet certain licensure requirements through the Colorado Department of Public Health and Environment. How that may be more of a business decision as to why or where they would open one, but I couldn't answer that specifically.
Do we know if these are normally tied to another health facility?
I do not know, but I think we'll know next month when we read that rule. But can we try to answer that between now and then?
Yes.
It's a good point, Mr. Potts, and we'll make sure that we have those answers when we hear that rule next month. Anybody else have any other concerns, questions? Thank you very much for your time. We appreciate it. We do not have anybody else available to give us previews, so you'll just have to get your own popcorn and read those rules when they come out. I was remiss in not reading the general announcements, and since if I don't, we'll have to redo this meeting, and I don't think we want to. I don't know that that's for sure, but the date and location of the next Medical Services Board meeting is scheduled to be held Friday, April 13th. 2018, beginning at 9 a.m. here at 303 East 17th Avenue, Denver, Colorado 80203 in the 11th floor conference room. And then in May, we will be in Ray. So in May, we're going to be in Ray doing another site visit, which will be very, very fun. We thank you all. And with that, I'm going to adjourn the meeting. Oh, and Dr. Lipolis, we thank you. We send our thoughts to Dr. Lipolis. She was very moved that you all signed a card last time, and with health issues in her family, we send her positive and warm, healthy thoughts. So I'm going to send you out into the world to do something fun and athletic in the next hour. No, not really. Take the elevator. Yeah. No. Yeah.
Stairs.
Right. Yeah.
You blocked their calendars for May.
I sent out, the whole.
There's some possibility I might be here for next month's meeting. I have a meeting that I'm